Speaker. So Martin Schumann is a full professor of neurosurgery in Tübingen at the Eberhard Karls University in Tübingen, and he's the chief of pediatric neurosurgery at the University Hospital in Tübingen. And Martin is a widely experienced and very well respected pediatric neurosurgeon on the European circuit and internationally as well. He serves on the ESPN, the EANS, and he's done tremendous work in multiple sort of areas of pediatric neurosurgery, mostly in the monitoring of intracranial pressure as it relates to certain types of hydrocephalus. He also chairs the Neurofibromatosis clinic at the Tübingen Hospital. So he's got tremendous experience in that sphere as well. And in that context, he's going to give us the next talk, which really involves the treatment of optic pathway gliomas. So Martin, if you want to share your screen and get started.
Yes. So you should see my screen now.
Yes. Mm-hmm.
And we are trying to start it here. Okay.
Okay, so, perfect.
Perfect. So thank you very much, Llewellyn and Mohammed, for the invitation to talk on optic pathway gliomas, which is a very specific topic again for pediatric neurosurgeons, not only in NF, but also in the non-NF cases. I hope I can share some ideas on this also quite controversial topic. Where is this role of surgery in optic pathway gliomas? So why is it not? Okay? So some general considerations. We of course are always treating in a team in pediatric neuro-oncology. We are a large pediatric oncology center here in Tübingen and a reference center for pediatric oncology and neuro-oncology. And so surgery is just one of 5 pillars in pediatric neuro-oncology. And I think optic pathway gliomas very nicely demonstrate that this is a team play and that you cannot solve these problems alone. We all read, I think, as medical students, Samuel Shem's House of God, and we were probably, I was laughing at rule number 13, the delivery of good medical care is to do as much nothing as possible. And in the context of House of God, that sounds quite funny, but the longer you're in pediatric neuro-oncology, you realize that this is probably the best essence of the whole book, that we really need to do as much nothing as possible in most of our tumor cases. But if we act, we have to act very decisive and as clear and radical as possible or as necessary. But in these eloquent area tumors, it is a little bit like climbing that Bianco crest here of Pittsburghina. On the shadow side, you have the loss of function. On the sunny side, you have the incomplete resection. And ideally, the goal of neurosurgery is to walk right in the middle on the crest, so achieving a total resection without losing any loss of function. Optic pathway glioma and optic hypothalamic glioma teach us, however, very impressively that in these type of tumors, you really need to walk on the sunny side. There is no way of losing function or visual function or hypothalamic function, because then you really decrease the quality of life of those patients tremendously. So our surgery needs to walk on the side of incomplete resection in the majority of cases if there's a surgical indication. And that's part of the talk. I want to show you that neurosurgery in these tumors needs to be well thought and well tailored. Because we are treating low-grade gliomas, which have a slow growth and which have a very high overall survival rate. The progression-free survival is much lower because there are always some changes in radiologies. Tumor might change contrast enhancement. They might grow a little bit and then stop again. They might. So it is a kind of benign disease, which is on the other hand very mean, but children in generally don't die fast of optic pathway gliomas. So when we saw this 17.5-year-old boy for the first time in 2016, we saw this optico-hypothalamic glioma, but going back, we discovered that this was already known in the year 2000 when he was 1.5 years. And you see, there's not so much change. There is change over these 16 years, but the tumor was here already. It was here in the pituitary stalk already. It grown bigger, but over all these years, he only developed hypogonatrope hypogonadism, and all other axes of the hypothalamus are okay. He has no diabetes insipidus. He has full vision. So what do you do with a case like this, which already shows you that it's kind of benign? So since we didn't know the dynamics between here and here, because there was no imaging in between, we did a biopsy, translaminar terminalis biopsy for molecular characterization. There was nothing special, no BRAF, KIA fusion or something like this. So we continued to observe, and until now in 2020, as on the last time, there's still no change. So we are treating kind of benign tumors in a very difficult location, which can be very mean on the other hand. So in optic pathway gliomas, it is like in real estate: location, location, location. These are the three things that count most, because you really have to analyze anatomy. Is this a prechiasmatic tumor only, so a truly optic nerve glioma? Do we have a mostly chiasmatic tumor, chiasma glioma? Do we have a total optic pathway glioma, also involving the optic tracts, and not only chiasm and optic nerves? Or do we have the full picture of the optic hypothalamic glioma, which contains the most vulnerable and area of the hypothalamus, which you absolutely have to protect in its function? So first of all, you need to carefully study the anatomy of the tumor. The next most important thing you need to know is the NF1 status. Do we have NF1 case? We see a much higher rate of indolent cases which are not that aggressive. In non-NF children, especially, we have more progressive cases. So NF are the more benign optic gliomas than in the non-NF cases. So we check for NF1 stigmata. The first thing you need to do if you have an optic glioma baby or child, to find out to which group is going to belong. And then the third most important thing is age. It is known that the younger children below 4 years or even below 1 or 2 years have the most aggressive course, and the older children have the more benign course. And you see these groups clearly differentiate in progression-free survival according to age. So there are three things: location, NF1 status, and age, which determine a lot of your therapy, of your strategy, and of your general approach to the patient. The radiological tumor characteristics, you have to know that we have several components, and we can have several components, and you have to look out of them. We have the solid enhancing, we have the solid non-enhancing parts. So these are mostly pilocytic astrocytomas, so they can do everything with contrast. And we have the cystic tumors. Looking then at the T2 signal, we have those strongly hyperenhanced at surgery, rather soft, fast-growing, often non-infiltrating, but pushing tumor components, which contain a lot of water. We have the normal, mildly hyperintense, which generally tend to be harder at surgery, are slower growing. They can be infiltrating in the border or genuinely infiltrating functional tissue, for example, in the brainstem area. Then we have the non-enhancing, which are most of the time rather the slower growing, harder infiltrating tumor parts. And then there are the cystic components, which again can be fast growing or slow growing, generally don't infiltrate, and they don't respond well to chemotherapy or radiation. So from that characteristic, there are surgical components or classical surgical components for surgical therapy. These are these strongly hyperintense, non-infiltrating, soft pushing parts of the tumor, and the cystic parts of the tumor. That are the classical ones which you can address surgically much better than the infiltrating, harder, slower growing parts, because they are in the more functional areas. There has been this now meantime famous consensus conference in 2011 in Paris, published 2013, where they defined for several types of glioma in children surgical indications. And for the OPGs and OHGs, it was agreed that we would mainly go for non-functional exophytic or cystic tumor paths with mass effects, that these would be typical surgical goals to reduce mass effect on functional structures, to remove fast-growing parts, to, for example, delay chemotherapy or radiation, gain time, or reduce tumor volume, which then is going to be treated with chemotherapy or radiation. So you debulk the tumor to leave a smaller volume for chemo or radiation. And depending on the location of the tumor, you choose different approaches. Anterior to the chiasm is the classic approach by subfrontal or frontolateral approach, midline or midline lateral. If the tumor extends lateral to the chiasm, we have the pterional or temporal approaches, subtemporal, transsylvian, transtemporal approaches. And if the tumor extends into the third ventricle upwards or into the basal ganglia, it's a classical transcallosal, sometimes transfrontal, transventricular resection. And for the cystic components, it's an excellent opportunity to use endoscopic cystic fenestration transventricular to decompress these typical pilocytic tumor cysts. Speaking about neurofibromatosis, we all know this is a rare disease, but it's one of the more common rare diseases located on chromosome 17. And the gene product, the neurofibromin, is a negative regulator of the oncogene RAS. So we have a RAS-MAP kinase pathway disorder, which is completely penetrant, but extremely variable in the phenotypes, even within the family. So children normally do not have the same phenotype than their parents. Only 50% of these children develop an OPG, and mostly they do so within the first years of life. If you haven't arrived with an OPG by age of 10, there are very minimal chances to get one later. And that is a very important information. Many NF patients are screened forever if they would develop an optic pathway glioma. After 10 years of age, you can basically stop. It's not going to happen anymore. So a big question, if only 15% of the children will get an OPG, is who will get it? And we tried to answer that question when we had all these whole genome sequencing methods, and we tried to do this with our colleagues from Heidelberg and Hamburg, and looked in 77 patients and found nothing. So basically there is no association to the position or the type of mutation and the likelihood and chance to develop an optic pathway glioma, because that would have been very nice if a little gene test in the patient on the level of the mutation would tell you if this is a risk candidate to develop a optic glioma, but unfortunately it isn't. So the question is now, do we have to perform annual MRIs in NF1 kids in the first 10 years of life? And I see quite a number of centers and children which get every year sedation to have an MRI in the first 6 or 7 years. And the French addressed in this very nice study that question. And they looked at 306 first MRI screenings, and only 45 of these children had an optic pathway glioma. So these are corresponding to the 15%. The mean age at discovery was 3.5 years. I told you it's below 10, mostly below 6 years. Only 13 of those patients were 13% were older than 6 years. Most of them are asymptomatic again. So if you have an optic pathway glioma, your likelihood that it is asymptomatic and not going to bother you is much higher than it is going to be symptomatic. And the progression of those asymptomatic, about 30% progressed, of the symptomatic, about 44% progressed. So only 9 of those 45 tumors became symptomatic, and mostly it's visual symptoms. 6 with visual symptoms had treatment, 6 of 45. This is 13% of all OPGs and only 1.7% of all NF1 cases. So you need to be aware, if you do an MRI scan in an NF1 kit, your chance is not even 2% that you discover a tumor that later on will need a treatment. So do we have to perform annual MRI in NF1 kits? Certainly the answer is no, because even the pure existence of a discovered OPG is no treatment indication. And I have seen children that have received 1.5 years of chemotherapy just for the pure existence of an optic nerve glioma. So there's no sense in doing these MRIs. And a volume progression of an OPG without any visual deterioration, again, is no treatment indication. You would not treat an optic nerve glioma just because it's growing a little bit if the vision remains perfectly or unchanged. And a change in contrast uptake, again, is without any meaning in these tumors. So what we need to do in these children is to perform biannual vision tests in NF1 kids. And the smaller the kids, on the other hand, and that's the main thing, the bigger is the challenge. The smaller kids are those which will have a tumor, which will have maybe become symptomatic, and they are more difficult to investigate. So if possible, we try to get these kids for once a year in a specialized ophthalmology clinic for children in our own center or in other centers where they really are very experienced and trained in assessing these small children. And only if we have the impression that there is any visual problem, we will do an MRI scan in children with NF1. Because they are very much stable. So here we see one bilateral optic nerve glioma stable over 5 years in this patient, no change at all. They are mostly diffuse within the optic pathway in NF1. They are very rarely exophytic, and they very rarely extend within the third ventricle. So these are no surgical tumors. They have a more indolent course, often stable, and the visual function is the most important thing. You can see the overall survival is excellent in this NF1 cohort, but the event-free survival is much lower because there's always some change of contrast enhancement, and that is already counted as a progression in this kind of analysis. Is the change in vision and the tumor volume correlated? So does growth mean that the vision is going to deteriorate? No, clear answer. We have seen everything. We have seen increase with change without increase of the tumor without change of vision or hypothalamic function. That is the most common scenario. You see some change in volume, but nothing happens. We have seen an increase concomitant with change in vision, but you can also see visual deterioration without any radiological change. And we have seen spontaneous regression in these children. So no correlation at all. You need to follow the function, the visual function. Now, which treatment options do we have in NF1 children? There's no place for radiotherapy in NF1, period. Because why don't we want to irradiate in NF1 patients? Because it is a tumor suppressing disease. A tumor suppressor is missing. So we have a high rate of malignant transformation, much higher rate after radiation for secondary tumors, for malignant transformation of pilocytic astrocytomas, or for other late vascular effects like moya type of development in after radiation. The standard treatment protocol is carboplatin and vincristine, and you see you have a third progress under therapy, 40% are stable, 30% improve in this study from Fisher from the United States, from Pittsburgh, and this European meta-analysis showed pretty similar results. So a third progresses, a third to 40% progresses despite chemotherapy. The other ones you can treat. There's an alternative which is less toxic and has less side effects. Is vinblastine monotherapy, which can have similar effects. And very much upcoming in the recent year are the MEK inhibitors, because they address the pathway that is genetically altered in NF1, like selumetinib or trametinib. The problem with the MEK inhibitors is they just about to be licensed. So selumetinib has just been licensed in the USA for NF1. They're extremely expensive, and healthcare insurance don't cover for them in many countries. And when you stop them, the tumor just continues to grow in many cases. So they shrink the tumor volume, but they don't kill it. And if you stop the inhibition, tumor might progress in a number of, or in a considerable number of cases. So you're not solving the problem forever, and we will have to learn a lot when to use MEK inhibitors in the best way. So what is the role for surgery in optic pathway gliomas or optic hypothalamic gliomas in NF1 patients? So basically, we contribute to disease control in the very well selected cases. I will show you some examples of blindness. If there's blindness in one eye, it's an excellent surgical indication to do something if you need to do something. There's a biopsy for molecular analysis. It's an increasing indication that we need the molecular profile, the genetic profile, the mutation profile of these pilocytic astrocytomas to address them with specific targeted tumors if they are resistant to standard chemotherapy. And we want to reduce non-functional masses before when chemotherapy fails. So if you have a prechiasmatic tumor where the blindness has already occurred and the tumor is growing and compressing the chiasm, and you're afraid maybe it goes to the other side, which not often happens, but it's more the compression on the chiasm, this is a very good surgical indication. So this child in the early ages was even radiated for the prechiasmatic tumor. She was blind on the left side, and now recently the tumor grows, and you have the deterioration of vision on the right side, and this is an excellent case. You see the big right tumor in the front, and you cut here the optic nerve where it leaves the optic canal. You remove the tumor, you stop in the chiasm, and you have a very nice surgical resection. The vision improved in this girl because you take off the compression of the chiasm. You can preserve the crossing fibers if you stop early enough, and preserve a full visual field on the remaining eye. If you have a predominantly intraorbital tumor, which presents with exophthalmos and pain, oncologists tend to treat that just out of reflex with chemotherapy, but it doesn't solve the problem. It doesn't take away the pain. It doesn't take away the exophthalmos, because these tumors don't shrink under chemotherapy. And again, that's an excellent surgical indication. So we have this 3-year-old boy with exophthalmos on the right. When this was diagnosed in July, his pupils were still reacting. In December, they weren't reacting anymore. So very, very fast growth. In 5 months, this tumor has doubled in size. The boy became blind, and then he was scheduled to go for chemotherapy. And we came to us as a second opinion, and we decided to resect the tumor from the bulb to the chiasm. I'll show you later a video in a different case. This is 1 month post-op. This is not tumor, what you see here in the orbit. This is the dura, because the tumor is around the dura, and to protect the orbital content, you do a purely intradural resection. And if you have an extended dura, like in this case, you have dura in here. And we see the chiasmatic border, and this is 3 years post-operative. So the dura has shrunk. We have no recurrent tumor. The chiasm is totally clean, and we have saved this boy from 1.5 years of chemotherapy, and he has a normal eye movement. He has no pain, no exophthalmos. So a very good surgical indication in a well-selected case. Another indication is the growing masses in non-functional regions which are resistant to chemotherapy. And this is a typical story, 11-year-old girl which had vincristine carboplatin in 2012 to 14, another cycle in 2017 to 18. Then she had a MEK inhibitor, severe adverse events, and she had to be stopped. Then she was for a year on bevacizumab. The tumor was progressing, and she had several biopsies and 2 partial resections and further progression. And now she was planned for large volume radiation in spring of this year, just a few weeks ago. And we were asked for a second opinion. And you see, between October 20 and March 21, the tumor progressed quite rapidly, but there's no progression in the chiasm. There is little progression in the hypothalamus, but the majority of the progression is in the basal ganglia and this large cystic component, which is also nicely seen here on the coronal slides. So we have a cystic component, we have a large volume component, which is hyper intense, and that is causing her problems at the moment. So we decided for a transcallosal resection. And you see, we took all the rapidly progressing parts. We did not take the hypothalamic part. We could have taken, to be self-critical, a little bit more out of that, not down here, but a little bit more posterior here in the hypothalamus. I think it was correct to stop here. Posteriorly in the cerebral peduncle, we could have taken a little bit more. So she was just discharged today. She's fine, she has nothing. Her vision improved a little bit again because the compression from the top has disappeared. And that is a good opportunity to help in disease control. But we haven't cured the disease on the other hand. So we still need to see how we proceed with the other tumors in this girl. And maybe she needs some more surgery. Now we switch to non-NF cases. We already learned that in non-NF optical hypothalamic glioma, the progression rate is much higher. And the French national study showed that the absence of NF1 and the age younger than 1 year, these are the 2 main risk factors for a malignant course in these tumors. The same thing shown in Ireland. The NF cases had 60% progression. The non-NF cases had 60% progression versus 24% of progression in NF1 cases. And especially the small children younger than 1 or 2 years is a very bad prognostic factor. These tumors will progress, and you don't have to wait in such young children for treatment. You can start right away with chemotherapy. This is a child, for example, with diencephalic syndrome, something very typical for smaller children with these hypothalamic tumors. You see multiple progressions or multiple seeding of the tumor already all over in the basal cisterns and the 4th ventricle, and the large diencephalic tumor, which needs to be treated by chemotherapy. This is not an upfront surgical tumor if the child is in a diencephalic syndrome. Most of them are pilocytic astrocytomas and these pilomyxoid type of tumors, which need more molecular characterization and have been known as a separate entity since 2007 in the WHO classification. They are clearly more aggressive. So you see the age of diagnosis is younger, the mean progression-free survival is significantly shorter, the mean overall survival is significantly shorter, and the local recurrence rate, even after kind of radical resection, is quite high. So this is a subtype which behaves very differently. In 2015, it has the first molecular genetics showed overexpression of several types, deletion of CDKN2A, loss of ATRX expression, or TERT-P mutation are typical features for these PMA-like aggressive pilocytic astrocytomas. So they need special attention, the dangerous ones. So younger children, more aggressive, less responsive, something you need to remember if you see this in non-NF cases in younger children. In general, still, the long-term outcome of these low-grade non-NF1 associated tumor is still good. So this is a study from Andy Anderson Cancer Center in Houston, and you see excellent overall survival. Of course, the progression-free survival, so there are radiological changes, but these children don't die. Again, the age difference and a clear molecular influence. So those with a BRAF-KIA 1549 fusion have a much more aggressive course and tend to need treatment. But we also have, for these tumors, we can use targeted therapy in addition to standard chemotherapy. But looking now at the different types of treatment, chemotherapy is the worst option. Radiation therapy is much better. If it would not be for the significant negative long-term effects after radiation therapy, this has become very clear. And the age for radiation, which was in the European recommendations 8 years in the previous study, has now shifted to, if possibly, 16 years or later in the new PSYOP logic protocol, because it has come up that there are problems and all these patients survive. They survive and they will feel their long-term radiation effects. But the diagram also shows that surgery, if it is indicated, is the most effective treatment also in optical hypothalamic glioma, if you can use it to the benefit of the patient. So I'll show you again non-NF cases. We have now acquired about 6 or 7 of those pre-chiasmatic intraorbital tumors, which we resect through a transfrontal transorbital approach. I'll show you a video on that because this is a nice pediatric skull-based surgery, which is really helpful for the patient. So we do a frontolateral craniotomy, and then we do an orbital roof craniotomy with a mini drill. So you take out the orbital roof. Then here's the superior orbital fissure, and then you drill the optic canal in these patients until it is totally open. You have to be careful to the median so you don't enter in the ethmoid cells. Then you take out part of the clinoid, like in adult skull base approaches. And after having here, you don't need to do a total clinoidectomy, anterior clinoidectomy, but you totally expose the optic nerve. Then you open the periorbital in a T-shaped fashion, which is important for later reconstruction because you have to reconstruct the periorbit. You have to preserve the branches of the trigeminal nerve, the frontal nerve, and the crossing oculomotor branches. And then you go in between the muscles, you dissect alongside the muscles and go straight down to the dura. And the dura of the optic nerve shaft. And inside, then you do an intradural resection of the tumor, and you maintain all the contents of the orbit outside. So within the dura, you're safe. Nothing can happen. You cannot damage anything if you stay inside the dura. So you can do debulking with the CUSA. Tumors tend to be pretty hard, so often you need to use the scissors. And then you cut as close as possible to the bulb, but you must not injure the bulb because you will have problems with an injured eye bulb. So you need to go close. This is one of the critical points. and then you enter the orbit canal until you see the CSF coming. You leave that part of the tumor inside the optic canal, and then you do a regular standard intradural subfrontal approach. You see the optic nerve where the tumor ends. You transect the optic nerve, which is quite painful for a neurosurgeon, which is trained to preserve visual function. And then is a little bit delicate, the dissection around the corner, because you don't want to open the dura there, because you need to get a watertight closure later on. So you do an intra-external dural resection until you have taken it out and preserve the ophthalmic artery. If you open the ophthalmic artery, it's like doing a hole in the carotid artery. There's no difference. Then you seal with a piece of muscle the optic canal from the inside, and then we seal it from the outside and reconstruct the orbit. And in the end, you can fix this. In the meantime, in the video, you will see I'm still using a plate. In the meantime, I'm using just PDS sutures, which works equally good, and you don't leave anything behind. After a period of swelling, you will have a very nice movement of the eyes, no anaphthamos normally, and from the outside, you see no difference to the preoperative status. So a good indication in selected cases. There's also another indication, like I showed you before in the NF, the same exists in non-NF cases, a 3-year-old identical twin with this large tumor. So on the first glance, you think, okay, this is an unresectable tumor. But in the second glance, you actually see that the optic nerve on the contralateral side is below this cyst. This is the optic nerve. This is the optic nerve. It is not involved in the tumor, and she was almost blind on the left eye and right eye, and she had a very good vision on the left side. So approaching this tumor here, we see the tumor mass, we see the carotid artery, and after reducing the mass, we have the left optic nerve, we have the right tumorous nerve, and you can then cut at the skull base, at the optic canal, the tumor, and you take it out from the chiasm, but you don't need to dig in here because you don't want to injure the crossing fibers. It turned out to be a rare case of a ganglioglioma of the optic chiasm, so it must not always be, or it has not always be a pilocytic astrocytoma with a BRAF V600E mutation, and we have a nice surgical result. And tumor residual, of course, inside the chiasm. And this was the immediate post-operative scan. We had also had some tumor residuals in the front here, which we actually inadvertently left. We didn't see that there was still something left. And this was in 2014. I still couldn't tell apart until now. I don't know which is the patient's because they are really identical. I always have to ask the mother, and you can't see from the outside. When she was 5 years old or 6 years old, we finally could confirm that she has a full visual field on her left eye, and the tumor is stable ever since. This was the last time when she came here 8 years after surgery with no tumor progression. So surgery can cure optic gliomas if it is the right case, and if surgery induces a senescence of the tumor and the tumor stops growth. Exophytic tumors with large mass effect 11 is also a good primary surgical indication. So this boy came with a very low vision on the right eye, a good vision on the left eye, hydrocephalus, cystic, polycystic tumor, very good case for a transcallosal resection. So we reduce the tumor and you leave everything that is problematic. You leave in the optic tract, you leave around the hypothalamus. So here's the hypothalamus on the right side. So you just stop there. There's no reason to go. And this is now, he was just here this Monday by chance, and this is now 3 years post-op, and the tumor has not changed in the last 3 years. So if you're lucky, surgery like in other locations of pilocytic astrocytomas, induces a senescence of the tumor residual. They don't grow, they stop. If you're lucky. If you're not lucky, you have gained time for the patient. Some of these tumors you might need to treat surgical when they are relapsing as soon as you stop chemotherapy. So this boy with a 5-year diencephalic symptom, impaired vision, got chemotherapy after endoscopic biopsy and a shunt. Then this was the end of chemotherapy, and mother was so stressed and traumatized by chemotherapy that she didn't show up for 2 years. She just was lost for follow-up because she swore she will never give her child chemotherapy again because it was so terrible for her and the family. So in 2018, she comes with visual decline, and he was not seeing that much anymore. And now the tumor has grown in the last 2 years. We did a transcallosal resection, vision improved, no hormonal deficit, no nothing. And then mother promised to come now for follow-up. She didn't do. She didn't show up for a year. And a year later, the same story. No visual deterioration. Tumor has rapidly recurred within 1 year. So in some tumors, you do not induce anything by surgery. Surgery cannot cure the disease. So I told her I'm not going to operate on your child again if she does not agree to any chemotherapy afterwards. And we talked to the boy, and he said he wants surgery and he wants chemotherapy. So we, again, a year later, did a transcallosal resection, reduction of the tumor. And this is now after 1 year of on and off vinblastine treatment. So we still have some compliance problems of the family, but it was enough to control the tumor basically in his status. And we will have to see how the story continues when we stop vinblastine in a couple of, maybe in another year's time. So in summary, surgery in optic pathway gliomas and optic hypothalamic gliomas is a team effort, and we just are one medication which you can use for disease control in a benign tumor disease, which has a very good overall survival. The surgical options exist in both NF and non-NF cases, but it's always well selected, and many cases will not need a surgeon, but other surgical treatments or just observation. In pre-chiasmatic cases with unilateral blindness, always consider surgery because you have nothing to lose and only to gain. The main goal in the most occasions is tumor volume reduction and removal of the mass effects before or after chemotherapy and radiation, to gain time or to, if you're lucky, induce senescence in these tumors and achieve cure. Thank you very much for your attention.
Thank you very much, Martin. That was a very comprehensive overview. Thanks so much. You clearly have a lot of experience with that. Do you find a lot of them come to you because of the NF clinic? I mean, from your numbers, that seems to be a reason why.
Partly, at least from the NF1 cohort, we get referrals from all over Germany, and but not explicitly for the non-NF cases. Okay. They are not coming because of the center.
Okay. Great. So look, we're running a bit over time, so I don't see any obvious questions pending still, John. I'm not missing any, am I?
No, I don't see any questions either.
Okay. All right. Mohammed, then maybe I'm just going to leave it to you to wrap up then. I think we're already half an hour over time.
Yeah, I just have one question to Martin. When you're doing this through the frontal approach and you're removing the orbital roof, do you need an ophthalmologist with you, like to identify the muscles? Sometimes the tumor is pushing the muscles upward and the fat, the periorbital fat, when you open the periorbital. Do you have some with you, or?
Yeah, we have a good collaboration with our periorbital surgery team. We have a pediatric team which also does the periorbital surgery. So all the first cases I did together with my colleague. And I think it is especially helpful and reassuring to decide where to cut behind the bulb, because the ophthalmologists really feel injury to the bulb, because this can induce a dystrophic process on the contralateral eye. This is this sympathogenic, I don't know the explicitly the word, but if you injure the bulb, you can get an immune reaction to proteins or certain antigens, which then can affect the other side. So they really fear that. And in the beginning, I found it very helpful to have the ophthalmologist also with the dissection within the orbit. In the meantime, the last two cases I have done without them. But I can recommend, if you have the ophthalmologist there and their experience, you would be stupid not to use it.
Mm. And have you ever used the mesh in the reconstruction of the
No,
roof?
never used the mesh. I always use the bone. And in the meantime, I don't do this plate. I only did this in the first two cases. Now I'm just using normal sutures. The alternative approach is that you only do a supraorbital craniotomy,
Yes.
take out the orbital rim and pull the eye outwards, so you can nicely take out the tumor parts inside the orbit, but you cannot remove the part in the optic canal. And then you transect, take out the intradural part, you take out the intraorbital part, but you leave the tumor in the optic canal. I have no personal experience with that approach, but I know some colleagues are using that approach. I'd rather prefer to remove everything.
Yeah, great. Thank you. Very interesting presentation. And does anyone have any questions before we can wrap
Yeah,
up?
I have. Martin,
Yes,
thank you
please
very
start.
much. That's a great presentation. I have a question that you go through a supra intracranial epidural approach and without removing the orbital ridge for the optic nerve tumor resection. And I had always some difficulty and concern to preserve superior rectus and also the branches of the south nerve. Do you have any trick for that?
I was just kicked out of my connection and I had to reconnect. Ted, can you repeat your question? I just
So when you go the subfrontal approach and then naturally you go from the roof of the orbit to dissect that optic nerve glioma. My concern is the going through the superior rectus. Obviously, you have to separate away, and also those branches of the oculomotor nerve, which supply. How do you have any trick to preserve them?
Yeah, you just go stepwise. So the first branch you see is the frontal branch of the trigeminal nerve. So you push this aside, and then I take two little retractors to open the channel, and then you have the crossing branches of the oculomotor nerve to the superior rectus and to the median rectus, and you have to do this in little windows. So you do the first resection before the crossing oculomotor nerve fibers and take the anterior part to the globe. And then after you have gained some space, you go to the next window. And then you have, in the end, you have where the muscles insert close in the conus region. You again have to work over a little bridge. And through these 2 or 3 windows, you can take everything out. And we haven't had any permanent damage to oculomotor function so far.
That's terrific. But those nerves are those branches are very small, right? I think it's those 3 years old kid.
Yeah, but it's okay. I mean, we treat many very small structures, and I'm sure you, as an so experienced microneurosurgeon, you will think they are big.
Thank you.
I think it also depends on the size of the tumor. That sometimes the optic nerve tumor is very big and pushing all the nerves and the fat. So
Exactly.
Sometimes it's very stretched and difficult. I had some problems with that. The same exactly. I had a third more nerve injury with ptosis after the surgery and superior rectus injury, where I opened the periorbiter, and there was an ophthalmologist. We could never identify it because the tumor came out with the fat and everything was under tension. Sometimes it depends on the size of the tumor also.
Yeah.
Yeah.
Well, I don't do this kind of optic nerve resection because most of the time the chemotherapy works. Probably your experience is different. So I would for 10 years or 15 years, I did not have any opportunity to remove that optic nerve gliomas these days.
The indication actually is pain, resistance to chemotherapy. Some of the cases we had chemotherapy, one even had radiation, and the tumor started regrowing. Then it is exophthalmos, which is bothering the child, and sometimes pain. And since chemotherapy is not reducing the volume of the tumor significantly, and these are the indications. I totally agree. The majority of all intraorbital tumors, there is no surgical indication, either because the patient has still some vision, which you don't want to sacrifice, or he lost vision and the tumor is small and he reacts to chemotherapy, no reason to treat it. So it's basically exophthalmos, pain, and resistance to previous therapy, which are the indications for this type of surgery.
Yeah, I agree with you, Martin, about this point. Great. That whenever it's impending the vision on the opposite side and going to the chiasm, and you lost vision in one eye, you need to preserve the rest. So sometimes you're faced to do the surgery.
Exactly. And if there's no exophthalmos or no pain, you can leave the rest of the tumor in the optic canal.
Okay, so yeah, any more questions? Yeah, okay. So thanks for all the speakers. I mean, we have had a nice 3 presentations. First, ependymoma, which take-home message is surgery, then surgery, then surgery. And then germ cell tumors, where you have your biopsy and endoscopy, and this dictates the rest of the treatment. And finally, the wonderful presentation from Martin for the chiasmal gliomas, where you have to have an oncologist and you have to diagnose and preserve the vision and sometimes do the surgery. So pediatric neurosurgery, as you can see, a lot of varieties. And we learned a lot today. And thanks for the great speakers. And I want just to remind you always that we do these webinars very dedicated to pediatric neurosurgery with a series of webinars, second week of the second Tuesday of every month. So it's once a month, second Tuesday usually. And thanks for John for the casting and the wonderful TV. We have reached a lot of the neurosurgeons. And thanks for everyone. Yeah, Lil, do you have anything to add before closing? Yeah.
No, thanks, Mo. I think you covered all of it. Just a special thanks to John. I think you've done a great job. You do this kind of completely of your own volition, so we really appreciate it, John. Thanks for your effort.
Well, I thank all you guys for taking your time off to educate the world. And I think the general neurosurgeons will get a lot out of this too, because as you know, that they don't see a lot of pediatrics, and it's good for them to see that. So we look forward to the next webinar, second Tuesday.